I would like to welcome Miss Erica Freeman, my sister, Miss Erica Freeman, who is the founder and CEO of Sisters in Loss, and she will be presenting to us today on holding space for NICU families after loss as we observe NICU Remembrance Day. And so Miss Erica Freeman is the founder and CEO of Sisters in Loss, a maternal health education company supporting Black women through pregnancy, infant loss, infertility, and grief. As a grief educator and doula, Erica uses storytelling to break silence around loss and trains organizations to better support grieving families. And Miss Erica Freeman is located in Atlanta, but she supports families nationwide. And so I will go ahead and stop sharing so we can welcome Miss Erica.
Let me go ahead and share with you all. I'm so welcome and honored to be here on NICU Remembrance Day as we talk about NICU babies and what does it look like to really hold that space and support them after they've gone through loss. So I see a couple comments of where you all are located in the chat. Definitely keep those coming. That also helps me out as well. Hold on. I didn't realize I paused my sharing. Okay. So, as she said, I am the founder and CEO of Sisters in Law. Sisters in Law started as a podcast 8 years ago of me wanting to find other Black women in the United States and around the world who had similar journeys of lost NICU experiences, fertility challenges, and really trying to develop and find a community online. From there, we have grown into a education company where we really educate around pregnancy, infant loss, infertility, and bereavement journeys, and really helping people find those support services on things that they need, from funerals to burials to lactation support to actually having a grief support group after they've gone through loss. I do have a rainbow baby after my storm of losses. His name is Maxwell. He did spend some time in the NICU, so I do have pictures in this presentation of my son in the NICU. I just wanted to make sure that you all were aware of those. You see photos of babies, of a baby. It's my baby during his 28 days in the NICU. And it definitely shaped my journey as a mother of all the things it took to get to bring him here. And then once he's here, having the challenge of what that looks like in the NICU, bringing him home, but also was there to see other families where they did not have the experience of bringing their children home. So we'll talk about that today. So this is the podcast. It is streamed everywhere, particularly in around 47 countries, our major cities. She mentioned Atlanta. I actually live in the DC area, but Atlanta is where most of the people listen to the podcast, outside of New York and Houston. Obviously the DC metro area, the Baltimore metro area, and in LA. So you definitely can find us anywhere. We really talk about the journey to motherhood, and our lived experiences as Black women in the United States, but also around the world, how similar the connection is. We talk about a lot about infertility diagnoses that affect Black women, like uterine fibroids, to polycystic ovarian syndrome, to uh, actually having unexplained infertility and endometriosis. And then we really talk about the underlying part of it is really talking about our faith and how our faith journey intertwines with our reproductive journey and challenges and all the goals that it takes and things that it takes to become a mother. This is a panel that I was on back in 2021 with the vice president at the time, where I was able to share a little bit about my story and the journey with Sisters in Loss. So, as you all know, and I'm pretty sure you've seen the maternal mortality numbers in the United States, which I think are a little bit more apparent. But we really don't talk about how infant mortality almost mirrors those numbers. And this is a rate that is per 1,000 live births. And it really focuses on, are we doing what we should be doing in a well-developed nation when it comes to not only having adequate prenatal care, postnatal care, but our infants are, how are they sustaining and living until their first year of life? And as you can see, the darker colors indicate in this chart. This chart is actually from 2021. I think it's right post-COVID, where the rates are higher, typically in the South, compared to the rest of the country. And we know a lot of that is very similar to maternal mortality, where it's due to historical and systemic racism within our healthcare system. Um, no different than the income range in this chart. This chart also is from 2021. It shows that it really doesn't matter your income rank, how much money you make. And it really is about race on how Black women, compared to their white counterparts, are experiencing more infant-related deaths compared to our white counterparts, or even some of our other racial ethnic counterparts. So basically, what does this mean? That typically it's very common for us to experience loss, even more common for Black women, women of color to experience loss. So we like to equate it 10 to 15% or 1 to 4. Birthing people do experience some form of perinatal loss, and this can be contributed to numerous different factors up into that first year of birth. But one thing that we don't do is we really don't normalize this conversation around loss. We don't really talk about it. There's a lot of cultural norms that we typically wait until baby's here, or that we are in later trimesters. A lot of parents may believe it's their fault. We talk about our birthing people's bodies. They're up for discussion for a lot of other topics, but we really don't talk about what loss looks like, how it affects us, how it affects our partners, how it affects our families, and how it affects us mothering our living children, right? The other part of this is that as we have um, grown to have kids later in life, a lot of those fertility challenges may influence the choices that we have when it comes to growing our families. And it may cause us to have to go through alternative reproductive treatments like intrauterine insemination or in vitro fertilization, or adoption, or having a gestational carrier or a surrogate in order to grow our families. And these are some reasons why I think we have to normalize this conversation, because it's so common amongst us, but also it allows us the opportunity to support people and help and guide people and really hold that space for individuals after they're navigating through their own challenges. One thing that we know is that loss is going to happen to us. We don't want to, we at some point in our lives, I think the harder losses are for those who do lose babies, particularly lose babies in the NICU, where you actually get to see, touch, hold. But a loss is a loss, no different than I think every birth is a loss as well. That how a person responds to the trauma that they experience is going to be different for everyone, no matter what trimester it happens or how many months old a baby is. They're going to experience it the way they're going to experience it. So I'm going to couple loss in today's presentation as a overall encompassing. Obviously, there's many different types of loss, from perinatal loss to post-loss, to sudden infant death syndrome, to losses that are very specific that happen in the neonatal intensive care unit. And I'm going to kind of couple them all under one, because I want to talk about it from a emotional and mental health perspective, and what we can do to really companion those who are grieving. How can we really hold space for them? How can we show up for them? How can we support them so that they are creating memories and understanding what are the options that they have available to make informed decisions around the quality and care that their children are receiving in those neonatal settings, intensive care settings, NICU or PICU settings, because there could be both, and we'll talk about the differences. But I always like to say that as a support person, as someone who is a doula, that our goal always is to make sure that we are thinking about all of the different ways people grieve. And I always like to think of grief as this like new reality of what's actually happening to them. When someone immediately experiences a loss, there may be this shock, this denial, those 5 phases of grief that people typically go through, this disbelief, where they're just kind of evaded from what this new reality that they're facing. They may have this encounter with this reality. They may have a lot of physiological changes that are happening with their body. They may still be in postpartum. They may be lactating. They may still feel this emptiness. They may still feel phantom kicks. They still may have lots of sadness from what's actually happening, some guilt and remorse that they may be experiencing. And then they may get to this point of not only acceptance as you think about those 5 phases of grief, but this reconciliation of what this new normal is for them, where they have to think about the baby that has passed on as creating this new memory and developing a new sense of self and a new context of what motherhood and parenthood may look like. So, as a supportive person, I always say that we should be coming into these grieving situations not only to open up that space, but really to really assist with like practical things. Encouraging people to express their feelings, their thoughts, to really be a comforting presence for them, supportive, encouraging for them, and then being okay with not saying anything. Sometimes just being there is enough. And we shouldn't go into some of those support roles as thinking that we have to move someone through their grieving process. We're just there to help guide them to resources that may be available, and that we aren't attached to whatever that outcome is because they will go through their process in the time that they're ready. Sometimes, but I always use this Maya Angelou quote that, people don't remember what you did. They may not remember what you said, but they always will remember how you made them feel. And sometimes the feeling is just showing up for people and just being there. And sometimes sitting in the silence is hard for us. But sometimes it's necessary because that allows people to know that you care for them, even though you may not have the words to articulate. Obviously, today we're going to talk a little bit about language and words and how we can support people. But the new reality of all of this is that when people do lose a loss, it's such a significant impact to them. No different than we do culturally with the death of an older child or a parent, a sibling, a cousin, a church member. We typically show up in a different way. We want to think about what are those cultural things that we do that we can show up in the same light for those who experience losses, particularly losses in the NICU. So I always like to think about mourning and grieving and really supporting people with making sure people understand what's actually happened to them, that they really feel the pain of the loss, which I think that they will, that we all help them remember the person that died and create memories for them, that they are working towards developing a new self-identity, and that they're searching for some type of meaning while they're receiving this ongoing support from their immediate circle, but we also are helping them guide them into finding a new circle of individuals who've gone through similar experiences. So for in the NICU, obviously when you think about babies being born and presented at birth, there's so many different ways that babies may end up in the neonatal intensive care or for older kids to go to the pediatric intensive care unit. And a lot of people may know prior to babies actually birth and delivery that baby may spend time in the neonatal intensive care unit. They may have a condition that's already there that they know, or they may have something that's overlooked during the prenatal visit where they may get diagnosed and have some type of birth-related injury that causes them to spend some additional time in the NICU. This could look like some things that may be preventable, some things that may not be preventable, like having some of these basic things that happen during the labor and delivery process, like having meconium that they've, if it, had some breathing problems or fetal
Mhm.
distress, having a breech delivery, babies may spend some time in the NICU, having, some other type of cord injury or forceps delivery, a C-section. We really don't know. There's many different ways that babies could be presented at birth and get moved to the neonatal intensive care unit depending on what's happening with them. In some hospitals where they do have smaller NICU units, they do put babies in the NICU for issues that they don't want to handle on labor and delivery, like jaundice or blood sugar issues. It just depends on the level of NICU or PICU care that the hospital may provide. So obviously there's levels of care. Three different levels. You have your basic level, newborn level, you have your level two, which is your specialty newborn care level. Then you have a level three NICU, which is more of a special subspecialty newborn care unit. And then these are typically no different than the PICU. Each of the different levels of care is determined about how much more extensive monitoring that the baby's going to receive while they're in the care of that particular hospital system. Where they're in an open area that has a patient to one nurse or multiple nurses or multiple patients to one nurse. Or if they're in a more enclosed area within this NICU or PICU where it is a one-to-one relationship where it's a little bit more intensive and they have more of a severity of life-threatening issues where it is a one-to-one relationship, the one patient to the one nurse that is monitoring them the entire time that they're there. So I want to say that most NICUs do have this level of care where they do section out the NICU or the PICU in this manner based on the level of care that the baby may need at that particular time. So when it comes to prematurity and we thinking about babies that do need care, a lot of babies who do go into the NICU may be considered premature, and these babies can be born obviously prior to your 38 to 42 gestational birth weight in your later trimester. It is the number one cause of neonatal death. Lots of babies that end up preterm um, um, typically do go into the NICU depending on their size, their weight, their gestational age. And then these are the different levels of prematurity from a micro preemie that's less than 1 pound before 26 weeks gestation, a very premature baby that's between 27 weeks and 30 weeks gestation, moderately preterm baby between 31 and 34 weeks gestation, and then a more late-term premature baby between 34 and 37 weeks. And each of these babies um, have different various things that may happen in the NICU setting based on how the baby's presented at birth. Some of the reasons that a lot of babies go into the NICU, depending on how they're presented at birth, particularly for these premature babies, they may go in for anemia, bleeding on the brain, low blood sugar, jaundice, problems breathing for most of premature babies, just because their lungs are typically underdeveloped, where they may need some additional support with lungs. This is actually a picture of my son and his probably first 12 hours of life in the NICU. He did get breathing support in that time frame after he was resuscitated at birth. Um, so yes, lots of things going on in this picture, particularly with my son, but also in general when it comes to patients babies going into the NICU. Some other things that I think that they do test in the NICU, and you typically will see a lot of when it comes to the cords and things that are surrounding the baby. They are going to probably do some type of monitoring of breathing and heart rate, or blood oxygen levels that they'll look at. They probably will also do a lot of testing around blood as well as X-rays, depending on the level of prematurity and what else the baby may need. And then there are just lots of common signs of prematurity that could happen once baby is actually in the NICU, and things that they are looking for and monitoring as baby continues to develop. Something else that I'd like to think about when it comes to NICU experiences and why it can be difficult, and how we not only support our clients or support people that we're going to hold space for, but really thinking about how we want to um, think about wraparound care for the birthing person, the mother, their parents, their support system around them. I think that we want to think about feeding. What does feeding look like for that birthing person? You know, are they able to feed? Are they able to provide nutrition via pump breast milk, or is it coming through um, some other form of donated milk, donated breast milk, or are they using formula or a combination of the two? Temperature is extremely important as well. Doing some type of kangaroo care or skin to skin is important for babies that can have this attention. And then just trying to create a bond with babies that have a lot of wires going everywhere, and we may not be able to physically hold them in the way and the manner that we want to. What are some ways that we can talk to clients, talk to parents that we're supporting, so that they could create that bond with their babies while their babies are in the NICU, prior to, especially if they have a fatal diagnosis and they may pass away. You know, what's things that we should be learning about babies? You know, how can we change the baby's diaper? Can we turn the monitor down? Can we ask all the questions about what all these wires are doing? Can we dress the baby in special clothing? Can we hold the baby? Can we feed the baby? Can we help with any testing? That there's still ways that the mother and the parents and their support family can still be there to really support the baby during their NICU stay. So as a support person, you know, I always like to think that our role in the NICU, these are all pictures of my baby. Y'all are seeing them all, his days in the NICU. Um, I always like to think that we have to remind the birthing person, the mom, the dad, partners, families, that um the wires that are on the baby are not hurting the baby. The nurses that are in the NICU aren't the mother or parent of the baby. That, you know, any physical defects, any injuries, anything that could be wrong, which is the reason why babies are in NICU, it's not their fault. Um, you know, they can touch and examine their baby. They still can fall in love. They still can have that bond. You know, they can, if they know that there is a fatal diagnosis with baby, that they have the ability to turn all the monitors and all the alarms off, that they have the autonomy to really make decisions for themselves, for their mental health, and for the time that they have with their baby while they're in the NICU. I think the biggest part of it all is not thinking that they won't grieve a fatal diagnosis too, but they will, and that they have the ability to create memories during that period of time. So when it comes to grief in the NICU, because grief gets heavy, especially as you navigate through and babies are actually in the NICU for numerous different reasons. Their clients may come up with so many different types of grief, especially the myriad of grief of having to leave the hospital without a baby, right? And the baby still in this hospital setting, and some days may be good, some days may be bad. And they may just have a negative effect on bonding with the baby. So you want to make sure that when you're thinking about holding space, that we think about some of these different types of way grief may show up through anxiety, through postpartum or post-traumatic stress disorder, through jealousy, through envy, that we want to make sure that we're thinking about reminding our support people, the folks that we're supporting in NICU experiences, that they can grieve, that it is okay, and that they want to make sure that overall, we want to make sure that their NICU experience is positive, even though it may have a negative outcome. So that could look like how people transfer hospitals. That could look like, as I mentioned before, if the baby's still alive, them going home, receiving a fatal diagnosis or a fatal call in the middle of the night and having to rush back up to the hospital. That this is such a lot of complex experiences on how they may feel, but it's okay to feel those strong emotions as they're navigating through. And that's how we support them, by letting them know, hey, it's okay that you feel that way. You want to think about how, if there is a fatal diagnosis, what are we going to do to really hold that space for them and make sure that they are creating the memories that they need? What is the visitation plan? How confidentiality is going to work within those close quarters? Um, is there any medical decisions that are there? What are the options around sustaining life? How do we say goodbye to this baby? Is there a farewell plan in place? And as support people, do we want to create one to help, move those obstacles out the way for them? These are just some questions, who do they want present in the baby's final moments? Is there a parent transition from sustaining life to passing? What is their cultural, spiritual beliefs around that? What are the special items that they may want in the room or brought to the hospital if there is a fatal diagnosis? Who's bringing those items? Are we going to keep them in a separate place? Um, can the hospital have warm blankets available if there is a fatal diagnosis? And we know that the baby's passing away, where they can wrap the baby still in warm blankets so they can still be warm to the touch after baby passes on. Um, and then, thinking about an autopsy and doing some additional testing on baby. If that's going to happen, do they want to have all the wires and tubes removed in that time where baby's transitioning, so they can have time to physically hold baby and spend time with baby prior to this fatal diagnosis. Once baby passes on, we want to hold space for them by giving them time, by being present and helping them create memories. Mementos are so important in bereavement because it not only helps preserve the memory of the time that they had with the baby, even if it was short-lived in their NICU experience and NICU stay, but it also allows the birthing person, their partner, their family to really have a positive outlook on such a traumatic and devastating loss. Some things that I like to think about that can be done um, are like a lock of hair, footprints, handprints, uh, professional photography of the birth, of the NICU stay. It could be part of the farewell journey. I love the organization Now Lay Me Down to Sleep. They do professional photography for babies who've passed away. Modes of hands or feet, you know, any linen that's available, any medical equipment cords, we are literally grabbing those mementos to help say babies say goodbye so they can create their own memory box or scrapbook to really make sure that they not only memorialize the baby, but also have a place to go in those moments, years from now that they can hold on to the memories of their babies. The biggest thing that I think that a lot of folks, their birthing persons, their partners may need is having support postpartum. We don't think of postpartum as a thing when people experience losses, especially when you have a live birth and you have a baby that's in the NICU. They're still going to go through postpartum physically. They're still going to lactate. Their body's still changing. But what's more heightened is how they feel about this grief that may be looming over them, this anticipated grief, especially if they have a fatal diagnosis, but also this grief of this profound grief of this loss. So they can still experience all of these postpartum feelings, from postpartum blues to postpartum depression to postpartum anxiety to post-traumatic stress disorder. And the most severe of these perinatal mood and anxiety disorders or mental health disorders is postpartum psychosis. All of these do need to be formally diagnosed with a licensed mental health professional. But it is something that still occurs, and if even more so heightened when a person experiences loss. So really, when we think about it, how does this show up for us? Because it is a heightened sense of trauma, a heightened sense of PTSD. A lot of anxiety may come up for them. They may have some social isolation. They may have some risk of higher depressions. They may have a lots of more triggering moments as they're walking through hospital doors, as they're walking back out to their cars, as they're trying to return to work and still go back into the NICU to really go through this experience, as they're grieving, and getting hospital bills. A lot of those things may be overwhelming and overbearing for individuals. And I always like to say that we really can't assume that if a person looks good that they're normal, especially after they've gone through such a profound loss, like a NICU loss. If they're having a bad day, or if they tell you they're good, they probably aren't. I always take people's concerns seriously, especially if they're expressing themselves, and how they feel. And then the biggest thing on how we really hold space, if we know folks are experiencing postpartum along coupled with grief, is just to let them know that you're there for them, and you're going to be there for anytime if they need you, even if it's just sitting in silence, as I've mentioned before. So, as a bereavement support person, as a griever, as someone who's really companioning someone, we really want to make sure that we are um, not only being there for them, um, honoring the spirit, but also that we are um, being curious and being very, I like to say being curious and being still, like, because that is really what it is. It really is being an intuitive listener, like listening to with our hearts, and that we are what we have been calling this presentation this whole time is really holding that space. Holding that space really acknowledges that there is struggles that the person that's grieving is having. We are being present with their pain. We are respecting this disorder, this chaos that is happening, but we're approaching it with this order and logic and reason, and really helping with tasks that easily can be eliminated and done on our behalf as the support people. I like to think of really supporting and companioning and holding the space is not thinking that we are responsible for helping that individual find their way out of grief. They're responsible for it, but our role is really to just really be there for them and honor their spirit. And how we do that is really by being honest with them, letting them grieve in their own way, respecting boundaries, building that rapport, always sending flowers, always being there, and that we don't compare losses at all, because we don't know the challenges they've experienced. And we think about how our language, what we say, how we refer to the baby, and then we just want to go slow and really give presence into what we do. Something else I like to think about when it comes to grief is helping people when we think about returning to work, when we think about having to go back home and care for other kids. If one child was in the NICU and other kids were at home, so they still are parenting other children, um, receiving those hospital bills, receiving additional baby things in the mail, especially after babies die, filing taxes, which is another big issue with grief that comes up for people, especially in certain states where, babies have to live a certain period of time before you can claim them on insurance. So a lot of that still comes up additionally, and it's something that you can really hold space with individuals as they are navigating through their own loss journeys. Lots of trauma that comes up that's associated with these losses. It could be some historical trauma that's right at the hospital, right? Like we all have hospitals in our areas that people typically say don't go to that hospital. Very similar. It could be environmental, it could be systemic, it could be lots of these mood and anxiety disorders that we're talking about, like post-traumatic stress disorder, postpartum depression. A lot of this can heighten the sense of trauma that may happen for these individuals. And it's a reason why we want to think about the language that we use when we're supporting them. You want to be aware of the language, you want to be curious with them. I always like to say when we are holding space for folks, we want to get eye to eye with people. We don't want to be like a looming presence over them. Like we want to ensure people know that we are there to offer compassionate and empathetic care. And that sometimes we may have to repeat options over and over again, especially if we are helping them create mementos that, we ask and we repeat, and then we talk to them about what does that look like and what are the options around it. I like to always plug having other support services available, like a bereavement doula that also helps clients really welcome baby, but also say goodbye to baby, right? And help them on the healing journey where they may have some additional resources that they can provide to be there immediately in the aftermath after a baby passes away in the NICU, but also what does it look like to navigate that first year postpartum or that first year without that baby. Some additional bereavement services that I think that are needed in that postnatal period, is like discharge instructions for the birthing person, the mom, for their partners, for babies who do get to come home from the NICU. What does that process look like? For those, there may be some cultural rituals that the family may want to do after a fetal demise or a fatality in the NICU if a baby passes away in the NICU, where they want to do like a baby baptism or baby blessing or some other type of ritual that's cultural to them. So those are some things that I think are great to have as a person that's really holding space for people. Um, and then making sure that all those mental mementos are collected and ready to go with the parent as they're getting discharged and moved out of the hospital, out of the NICU, back to what their new normal is. Something that typically comes up in postpartum is lactation. We talked a little bit about just lactation in general, but typically after babies pass away in the NICU, a lot of moms may want to just dry their milk up and not want to continue to pump breast milk unless they have other children that they may want to use the breast milk for. There are also options of donating the breast milk as well as just pumping from a healing perspective, just so they can heal as they donate the breast milk for their own satisfaction, knowing that this breast milk is going to a good cause. Some other options that I liked during bereavement, I had a few of them that were there for the NICU stays. I also like to think about a cuddle cot or carrying cradle. This is a life preserving bassinet. They typically have these in labor and delivery units. I very rarely see them in the NICU, but that is an option as well. Basically, it is a cool-in bassinet that baby can be placed into that preserves the body of the baby so the baby doesn't have to get moved to the morgue every day. They can actually keep the baby with them. So that is another option that can help a parent as they are creating memories, as we're gathering mementos, and that they get that extra time with baby before we think about what are those next options and the next steps in the journey. I like to think about all these mementos, all these memories we're creating is just to make sure that the person has less regret long term in their care, and they have an overall greater experience with such a traumatic experience. The hardest part of this journey of loss is really saying goodbye and thinking about helping a family plan for a funeral or a burial or cremation. We want to make sure that we think about all the options that are available for them that can be there, whether that is organ or tissue donation for the baby, depending on the baby's condition. Um, Saying goodbye, physically saying goodbye to the baby and having the baby hand off to the hospital or to a funeral home, exactly what they're going to do with the baby's remains. I think that's important. Is it going to be used for dedicated to science? Are the remains actually going to the funeral home to be properly embalmed and buried after an autopsy is done? Or are they going to cremate the baby? And I think that these are viable options, no matter how baby's presented. And these are things that we want to think about, making sure that, particularly if they want to cremate the baby, that, all the um, remains are properly sealed and secured, that all the proper information is up there about the baby's name, their birth date, their death date, mom and dad's names, and all of those things are listed to really support them as they say goodbye. Something else that we can do is ensuring that they have a memorial service or a funeral, and really being there to hold that space with them as they navigate through, even if it's something within the funeral home or even at a grave site. There are lots of graveyards do have special areas, particularly for babies who are under 18 or children. They do have areas. So that could be another option for people if they want to bury their baby, particularly in that children's area in the graveyard. The hardest part about this first year of bereavement is when people stop calling. So the first month after baby dies, typically folks are calling, checking in, visiting, sending flowers, maybe sending food. But by month three, the person is back to work. They're back to this new normal, this life without this baby. A lot of the phone calls and visitations and food has stopped in, and they just may be starting to really grieve this profound loss. And really, what does that mean for them? They may go through the rest of the year just going through, just trying to move on, trying to grieve, going through the motions. And but they may not know what triggers them. How we really hold space for folks is really to remind them that we're thinking about them, that we are, praying for them who have faith, that we really are there during and can be there during those difficult moments. I always like to acknowledge people who've lost babies during those moments that folks may not think of reaching out to them. Obviously, the birth date or the death date is one date, but like Mother's Day is another one. Anytime during holidays, because holidays typically are hard for folks who are grieving as a whole, but definitely for people who are grieving the loss of their babies. So I always to remind people that to bring out those mementos during that time, create a new memory, think about how we can plan a special activity to really honor the baby during those difficult moments and those significant anniversaries in time. One of the major things that I love about the work that I do is that I get to support people emotionally and mentally on their journey. And I can't toot my horn enough for making sure that as someone who's holding space for people, that we think about creating more grief support groups for moms, for dads who've had difficulties navigating the NICU journey, but definitely have had a loss. Grief support groups really help not only normalize their feelings and experiences, but it really gives people permission to grieve, permission to cope, permission to live a happy life, and not only to move on, but I like to say that we move forward and we move through. So it helps them like to move through those difficult days, those difficult challenges, and creates a sense of community around them of people who've been there, done that, and are there to support them through it. So, grief support groups are so necessary on this journey. And this is another way that you can really guide people to make sure that they have a place to go after they've gotten discharged from the hospital, after babies passed away, that they have a place to go where they can share those stronger feelings and those strong emotions, and that they can learn how to create new traditions in their family as they honor the loss of their baby, but also think about themselves as they are going through this new reality. Lastly, here, I have a list of activities that I love that you could do with family. I love this book. It is a postpartum anxiety workbook that has a lot of practical tools, tips, and tricks and guides to really help people navigate what postpartum looks like, but also what grieving looks like. Because lots of times grief may show up as anxiety in people. And these are some activities that I love to do with families, whether it's, creating a family tree with your child, making sure the child's name is everywhere, pictures are everywhere if they have pictures, so that the child is not forgotten throughout the journey. That is all. I would love to open it up for questions. And this is my contact information if you would love to stay in touch with me.